TopMedTalk.
Well, hello, I'm Desiree Chappell, and this is TopMedTalk. TopMedTalk is a global perioperative medicine podcast where we focus on everything from high-level economics all the way down to translating evidence-based practice for the ground-level providers. Now, we're also the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. And to hear more about that, I'd love to introduce my co-host, my partner in crime, who is also the editor-in-chief of TopMedTalk, chair for the upcoming EBPOM World Congress, and chair and professor of anesthesia and critical care, Monty Mythen. Hello, Monty. How are you?
Good, Desiree. I'm actually, very good. The sun is out here. I know we start talking about the weather. People said, can't you talk about something else? I'm British. Okay, so get over it.
That's all you do. This
is going to be reshown, but right at the moment here, it's spring. The sun is out. The local bars are open if you're prepared to sit outside. Tea's being served, and almost everyone above a particular age has been vaccinated. So what could possibly go wrong?
Fabulous. Well, Monty, it's been a long time since we've been able to sit in person and have a conversation, but we have kept TopMedTalk going by fabulous conversations over Zoom and virtually. It's worked pretty well.
Coming up on a year and a half nearly, is it?
Yeah,
well,
almost close. Well, it was March 13th last year. World closed down. So we're in the maybe not midst. We're kind of coming out of the fog.
Well, since we did a live show,
so hopefully
it's probably a lot longer. Anyway, we're looking forward to doing those again. But in the interim, everyone's been very, very generous with their time jumping on calls like this, and the conversation has been as good as we could hope for. And EBPOM perspective, we recently launched the Irish Perioperative Medicine Group. Some of our friends from Argentina have reached out about a new South American perioperative medicine group. And earlier this week, we had the Welsh Perioperative Medicine Group had an anemia workshop that over 1,000 people came to. So the world of perioperative medicine. But that's not what we're here to talk about today.
It's not, Monty, but I'm glad you mentioned EBPOM, and we'll talk a little bit more about that at the end. But I'm excited to hear about all the great opportunities coming up in the next year with EBPOM.
Did you say it's snowing where you are?
Oh, I did. Yeah, I'm from Louisville. We don't talk about the weather here. We talk about basketball.
It's April, just so we know, because when it goes down, it's 2021 and it's April or whatever it is at the moment. It shouldn't be snowing should it in Kentucky?
No, we very rarely we have a late, it's early spring snow. And Derby is a thing around here, not the Derby, as you say.
It's a horse race.
The Derby, the horse race. Yeah, it's the first weekend in May. And I don't think it's happened since I was born. Maybe once that they've had a snow on Derby, which is just in 2 weeks. Oh. So we occasionally get a late or early spring snow, but there's about an inch out there, which is crazy. But it's going to be 50, almost 60 degrees today, so it'll be gone here in about a couple of hours.
Segueing neatly, if I may, because I've thought about this since you mentioned it was snowing, from snow on the ground to frostbite. We did a podcast with a friend of yours, Bill Prosser, as I remember.
We did
a while ago, talking about cryoneurolysis, which we got very excited about, which I think I remembered as a sort of form of recoverable frostbite. Yeah. And I said, we know it's coming to town. We're promised it's coming to Europe, along with liposomally encapsulated bupivacaine, which we're very excited about because we've been slow to get this. And I said to you, can you find me some people to tell us more about it? Because we're excited we might get our hands on it now. And you've done that for us. So thank you, Desiree.
I did. It was actually that conversation, setting that up was already in the works before you even told me that, which was serendipitous. It's great. But, Monty, our favorite conversations on TopMedTalk are those where we have the opportunity to talk to early adopters, right? Those innovators, those providers that are kind of like forging new pathways to improving and enhancing what we do for all of our patients. So today we have the pleasure to sit down with two of those early adopter orthopedic surgeons. They're changing up the way that we treat joint pain for surgical patients. So it is my pleasure to introduce Vinod Dasa, who is an orthopedic surgeon at the LSU Health New Orleans, and Dr. Josh Urban, who is an orthopedic surgeon in Omaha, Nebraska. Gentlemen, thank you so much for joining us.
Thank you.
Thanks for having us.
Tell us a little bit about yourself. Vinod, if you'd like to go first.
Sure. So my name's Vinod Dasa. I'm an orthopedic surgeon in New Orleans, Louisiana. I'm the vice chair of the orthopedic surgery department here. I'm also director of research. And our research interests here are merging population health with basic science. And we're doing a number of health disparities and health inequities research projects. And then on the clinical side, my interest is mainly in adult knee replacements, arthroscopies, things like that, trying to figure out, a better way of providing care for our patients. And I think management of pain and function postoperatively is kind of one of the areas that we've all struggled with over time. And so that's been a big interest of mine clinically. And most of our patients, generally speaking, at least here in the US, are Medicare patients. So generally over the age of 65, probably the bulk of my practice, about 70% of my practice is that age group and that kind of bracket of patients, and the balance what we call commercial patients or commercial payers, younger patients. And our patients are varied. We've got a fairly diverse patient population. About 40% of my volume is non-white, if you will. And so we've got a kind of broad range of patients that we treat with different expectations and different backgrounds. And so we have to meet all of those expectations. And so that's where I started becoming a lot more interested in, managing these patients postoperatively, because, their patients are not simply copies of themselves. And so we've got to meet them where they expect to be. And so how do we do that more effectively?
Josh, tell us a little bit about you. Omaha, Nebraska, middle America. What's your practice? What are you doing there, and what's your practice look like?
I am mostly a clinician. I'm an orthopedic surgeon specializing in hip and knee replacements, about 50 and 50 with respect to numbers. I'm part of a large orthopedic group here. We have about 30 physicians, which is pretty big for this area of the country in this type of metropolitan area, which is considered small to medium. Roughly about 1 million people with the surrounding suburbs. We have a less diverse population, it's just the demographics of the area. Personally, I do have an academic leaning in residency, which is 15, 16 years ago, a lot of publications with hip and knee replacements, but kind of devolved from that, if you will, into more of a private practice-based lifestyle in the last 5 years, and really have been kind of sucked back willingly into the academic world with this cryoneurolysis that kind of fell on my lap a little bit, with the guidance of Vin here along the way. And it's been an exciting tip of the spear kind of feeling to promote this, to see its effect, cryoneurolysis specifically in total knee patients. And that's where my focus has been lately, is to optimize that process, to see what effect it has on patients afterwards, in what we consider, a historically painful procedure, and one that takes a long time to get over, total knees, that is. Hips have been, I think we're fighting now about length of stay and, opioid-free, and hips are noticeably easier to take care of from a surgeon standpoint. And I think patients get better quickly and faster. So I've kind of focused more on the knees lately.
Well, I'd like to kind of just take it back a little bit and discuss what was life like for you guys before COVID. Vin, I'll let you go first on that one.
I'd say before COVID, we pretty much had a very structured routine, and, we weren't worried about COVID testing preoperatively, and, we weren't worried about, is this person going to be staying 2, 3, 4 days, or maybe even ICU stay. And we were, I think, a lot more willing and able to treat more complex, sicker patients and things like that. And I think since COVID, we've really backed off, I think both on the provider side, but also on the patient side, in terms of what we're willing to tackle, and also in the context of what our hospital is capable of doing. And so, in other words, if we had a surge or we had an increase in admissions, and we were running short of ICU beds, then, we had to really back off on, what patients we were willing to treat. And then now the sicker patients are thinking twice about coming in to see me. I can think right now of a dialysis patient right now who's absolutely paranoid about having their surgery, but they're stuck in a wheelchair. And so they're kind of in this, between a rock and a hard place because they don't want to have surgery because they're scared what happens when they leave the hospital. Again, this was kind of pre-vaccination or the surge of vaccinations recently, versus, injections aren't working. I'm stuck in a wheelchair. I got to go to dialysis 3 times a week and I'm just miserable. And I can't live life like this. And so that's kind of my prototypical patient that I think of when I think about pre-COVID versus post-COVID. How do we handle those folks? Because I think we all agree, the 60-year-old healthy person, blah, 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 and, they'll get their total knee or whatever, without much of an issue now. But it's kind of these tougher patients, I think, that are a little more difficult to manage, and I really struggle with that.
Can I ask, are you seeing a lot of deconditioning, which is impacting on the quality of the joint recovery? Because we seem to see around us in London and the United Kingdom, in the National Health Service, almost everyone is deconditioned. And I mean, like everyone, staff, the whole 9 yards, because we've just been doing a lot of sitting around.
Yeah.
Yeah. I mean, I think it's deconditioning both psychologically and physically.
Yeah.
Because I think everyone's just, psychologically just at wit's end. And then likewise, we've actually pulled some data recently looking at some of our outcomes, and we do see a decrease in outcomes in our immediate post-COVID patients compared to what they were going into COVID. So again, it's a small number. I don't know what to make of it just yet, but I agree with you. Even objectively now, we're starting to see some differences in our PROs compared to before.
Yeah.
And the socioeconomic factors, just 1 second, Desiree, because before, when we've looked at our data in the past, we'd have like a 1-day length of stay discriminator for our most well-off patients compared to our least well-off patients. We're just a bit worried now that gap's going to widen, because I think being locked down in COVID was very different if you were wealthy compared to being locked down in COVID if you were poor.
Yeah.
And Josh, you were shaking your head too. Do you want to comment on that?
Yeah, well, our experience was a little different. We have Vin's at a tertiary care center, and we are not. We have our own hospital. We do have privileges at tertiary care centers for sicker patients. So we had kind of a unique dynamic with COVID. Pre-COVID, we had a what we call our same-day surgeries, outpatients. Those words are mixed. You can define outpatient in lots of ways, but to be clear, my definition of outpatient is you go in one day, you come out the same day, not 23 hours or some, manipulation of the wording. And so we call it short stay. So our short stay program was live and well. And I would say maybe 15 to 20% of total hip and total knee patients were doing that. We made it an option pre-COVID. Hey, do you want to do this? And of course we would introduce that and ask that of appropriate patients. If you're 90, get wheeled in by your granddaughter, have oxygen prongs and an oxygen tank. And, we're not bringing that up, but younger, healthier patients, and that younger is relative. We've done 80-year-olds same day. It just depends on how physiologically appropriate they are. So pre-COVID, it was an option. Do you want it? Do you not? 80% of people said, let's just spend the night. No problem. So when COVID hit in this area, our hospital became a elective surgery only, and you could not occupy an inpatient bed. Elective outpatient surgery. So what we had to do, and that was a state mandated decree by the governor, and we found out, and this happened to be in November for us. So for those of you who don't know where Nebraska is, if this is a global audience, it's in the center. Things kind of reach us last, everything for that matter. And so in November was kind of our high tide for COVID, where we were really stressed with our hospital beds. And we do have tertiary and university hospitals in this town, and they were assigning those beds for what we anticipated was going to be a bigger surge. And they kept our hospital as an overflow hospital, so we couldn't use their beds. So basically, if we could do a short stay total joint and get them out the same day, we did not use any resources for the community. And then also the timing of that was important, because in America, Q4 is historically very busy for surgeons because of met deductibles for private insurance patients, and they want their surgery done. If you can get it done in December for free, in January it's a full price, they're gonna want that done. So we found that money and pain are very powerful motivators. And I know that's not an epiphany for a lot of people, but it was very interesting that the day that the mandate came in and we went to a short stay only patients, a lot of them signed. I mean, that 80% I don't want to do it became 100% I do want to do it because of those two motivators. And then that decree only lasted about 4 or 5 weeks here. And the millisecond the governor pulled that, all the patients knew about it. They come into clinic, I'm going to stay the night. I changed my mind. So it really became we became more efficient in our total joints. We know that we can do them, and a vast majority of people can actually go home with this. Vin is right. There are going to be the sicker, patients that are just never going to be appropriate for same-day surgeries. But we learned a lot of lessons. So necessity is the mother of invention, and it was in this case for sure. Absolutely. For us.
And Vin, did you see a social disparity, coming from a tertiary care?
Yeah, and especially when we talk about vaccinations and access, do you have to be vaccinated to have surgery, or do you not? I'll tell you, when the vaccines first came out, one of the questions I asked our hospital is, should our patients that are unvaccinated about to have a total joint replacement actually get the vaccine, right? Mm-hmm. So anyone that we're booking, should they qualify for that vaccine? Because now post-operatively, they're immunocompromised, if you will, mm-hmm. and they're out in the community and they're unvaccinated and they're forced to be out in the community because they got to rehab and do everything else. Is it fair? So then if we talk about health disparities, who's going to be able to access me to then potentially get a vaccine? And so we at our hospital had created a protocol where anyone that got booked for surgery qualified for their for vaccine preoperatively, because I didn't want to put people out in the community and force them to be exposed, because that's kind of a no-win situation for the patient. And so then if we start thinking about health disparities, that starts factoring in and who has access to what resources. So it gets very complicated very quickly. And, because the vaccine, at the time was Pfizer. And so you had to get your 2, and then did they have transportation to get their second one? Yeah. And obviously if you don't have the resources, you don't have, some of my patients actually, take the bus to get to where they need to go. And to therapy, they have bus tokens, so it can be challenging for a lot of people when you've got a lot of logistics involved, specifically in knee replacements. Unlike a lot of other surgeries, there's a lot of logistics and a lot of resources that have to be deployed compared to a lot of other surgeries, right? It's not a carpal tunnel, even a total elbow, total shoulder. You can walk, you can get to where you need to go. You can even drive, really, but when it comes to knees, foots, and ankles, it's a different animal. So, it's all relative.
Yeah. Well, so we've seen this major shift, right? From, we have the option to have a couple nights in the wonderful hotel of hospital with their wonderful food and, or, same day. And, I think there was obviously a shift, as Josh had mentioned, towards same day procedures. And let's walk through about how do we actually accomplish something like that? Because I think this is getting to where we want to talk about different interventions. But, one of the things locally that we have been discussing a lot is the term opioid-free anesthesia for these patients and how that really contributes to getting these patients through. Joshua, you had mentioned this as some of the techniques that you guys use. So let's just stick a pin in that for a minute and talk about, what that looks like for patients and for providers.
Well, I think first of all, the lessons that we learned from that pre-COVID to COVID is that you have to have patient buy-in. Mm-hmm. You have to have somebody willing to do it, and you have to have facility-wide buy-in. You can't have the janitor walk in the day of surgery going, stay in the night, right? And boom, it's over. So everybody has to be on board. You are going home the same day. And what's key in that, especially with total knees, is pain. And like I said, this is historically a painful surgery. Most people signing up for a knee replacement know that. Patients, as we talked about earlier, are more educated. They get online, social media. I don't know how prevalent this is in your world, but we have a Nextdoor app. I can't tell you how many people use the Nextdoor app in my community. It's basically a neighborhood, and the word neighborhood is used loosely. It could be 4 square miles, depending on how big the neighborhood is. Around here, that's a neighborhood. And, people come in and I'll ask them, how'd you get my name? Well, the next door app, a bunch of people recommended you. So it's basically people in their small little world who talk. And it's a lot of old ladies on there. My wife gets on it and tells me about it. But people are educated. They know this hurts. They know it's going to take a while. And they're looking for people who are surgeons who are tackling that and are trying to make that better. They're interested in buzz phrases like opioid-free, opioid-sparing. The cryoneurolysis makes this better. That's been out there a lot. We've been doing cryoneurolysis for our total knees now for 3 years, and it's out in the community, and people talk about it. And they want and this isn't an epiphany again, they don't want a lot of pain with this. And they know it's coming. How do I get less pain, doc? And show me how you do this. And that's what they're interested in hearing it. And people gravitate to practices that practice this technology because of that reason.
Could we drill down a little bit on the cryoneurolysis? My simplistic understanding of it, when I've spent a bit of time in the mountains, I understand frostbite and I understand frost nip. And the frost nip is when cold damages a nerve and you stop feeling pain, but it comes back. Is that anything at all to do with cryoneurolysis? And if it is, how do you do it? How do you give some out?
The way I describe this is basically we've been used to cold, like you said, for our entire lives, right? And so when we fell and you hurt your wrist, what did mom do? She put an ice pack on your swollen wrist and your pain went away, as did the swelling, right? So cold to treat pain has been around since the beginning of time. And so what cryoneurolysis essentially is we're using cold to induce second-degree Wallerian degeneration of the nerve, okay? So essentially what we're doing with this particular device, and the only one on the market that really does this, is creating a tic-tac-sized ice cube underneath the skin. And when that cold hits the nerve, it shuts the nerve off, and then your pain goes away. We know nerves in general regrow approximately 1 millimeter per day. So depending on where you freeze the nerve or shut the nerve down, that's how long your potential pain relief is going to be. So if you target sensory nerves, especially around a painful joint like the knee, the further up you go, the longer the pain relief can be. And so that requires understanding neuroanatomy. It requires understanding musculoskeletal anatomy. It requires understanding where the pain generators are, what nerves are responsible for pain in different scenarios. So I submit to you, in knee OA, the pain generators are different than in surgical knee pain, okay? And then we can distinguish later on, if you'd like, between the femoral nerve versus the tibial nerve, which then gives off the branches of the geniculate nerves, the deep geniculates versus superficial geniculates. And so it requires kind of a deep understanding, but the short and sweet is we're essentially introducing cold to the nerves. The nerves responsible for that pain are shutting down and then regrow over a fixed period of time. The nice point about this is the cold that we're generating is minus 88 degrees. And so at that particular temperature, nothing is destroyed, unlike radiofrequency ablation and some of the other treatments that are out there that are burning or destroying the tissue. At this particular temperature, the only anatomy that's impacted is the axon. So the myelin sheath, the Schwann cells, but the epineurium, perineurium, endoneurium is completely maintained so that nerve regrows along its original path.
And so my simplistic mind is telling me we're trying to do a nerve block, but we're exploiting the cold phenomenon. So the anatomy and the understanding of the anatomy and trying to maintain muscle power and cutaneous sensation while taking the bad pain away is all in play. It sounds too good to be true. But if you say to me, it sounds great. Bring it on.
Well, Monty, you hit the nail on the head. What are our most effective pain relieving modalities when it comes to surgery? You can throw oral things at them that get absorbed systemically, opioids, anti-inflammatories, gabapentin. You can block the nerve, and actually, like what you guys do in anesthesia, spinal, adductor blocks for total knees. Those are the most effective. When you shut down the nerve, that's more effective than taking a systemic drug, right? Which goes everywhere. So this is a long-term nerve block. This takes a while to come back. It always comes back. We're going after sensory nerves, so you can get as many of them as you want to numb up that knee, and there's no motor involvement based on where we're going. You can get motor involvement if you go high enough, like Vin said, but we don't go high enough. We avoid the motor branches. So the best way to deal with pain is to affect the nerve. And that's what we're doing.
And the device itself, sorry, Desiree.
No, you go ahead. Go.
I was going to say the device I've seen on websites looks about the size of a sort of handheld blender. Looks like, I might be wrong in this, but it looks like a single handheld. Sorry, does that translate?
Yes, it does.
In the kitchen type of thing. And it looks to me as though the business end of it is at the pointy end, and you get it in the right place and you go at it. Am I making it too simple there?
Yeah, no, you're right on. So it's a handheld device, and it deploys nitrous oxide. So what it does is it converts liquid nitrous oxide into a gas, and you've got there's two versions of this. There are 3 27 gauge needles that are about 8 millimeters long, or there's a single 190 millimeter needle that you can target using ultrasound. So either one, the point here is if I can put that cold around the nerve, I can shut it down. So however way you want to get there, whatever needle you want to use, the point here is if I can get cold at that nerve, the pain goes away. It's as simple as that. And so the concept is pretty basic, but the tool is fairly elegant in the way it was designed. And actually, it started, believe it or not, Monty, in Europe. The original company was going after motor nerves for the forehead to get rid of wrinkles. And so they were freezing the nerves, Botox. They were going after Botox. And as you can imagine, that's a pretty heavy lift. And so they did a little pivot and came to the U.S. and targeted sensory nerves for pain instead of motor nerves in Europe.
Wow, that's incredible. Well, Vin, is it pretty user-friendly? I mean, in the hands of someone that knows neuroanatomy, is it something that you use ultrasound? I mean, for us now, the standard of care in anesthesia for doing nerve blocks is ultrasound guidance. What's it look like for this?
So there are two predominant techniques. One uses the 3 needle design that I talked about, and you have a landmark technique where based on the about 7 centimeters proximal to the patella, draw a line along the anterior aspect of the thigh, and then we treat along that line because we know the AFCN 80-90% of the time runs within that space. And then we target 2 branches, and then the LFCN also there. And then we, for the landmark technique, again, we draw a line about 5 centimeters medial to the patellar tendon, and then we simply treat along that line. So numb up that region, and then we'll go ahead and treat along that line. So that's the landmark technique. That's a technique I used, and that's the technique that a lot of this started on. But Josh has really pioneered kind of the next level of technique where they use ultrasound and the long needle. And you can really use both. What I've seen, and Josh can probably speak to the ultrasound-based technique, the technique resonates with different providers. So I think most orthopedic surgeons who are not facile with ultrasound will probably use the landmark technique, whereas a lot of the anesthesiologists or those folks that are comfortable with ultrasound probably prefer the 190. I'll let Josh speak to that.
Yeah, Vin's right. This is the nice thing about this cryoneurolysis, which is iovera is the name of it, is it can appeal to the masses. So there are 2 predominant techniques and kind of a bastardization of both of them, providing maybe a third option. So the first option, as Vin said, is a landmark-based technique with the trident needle, the 3 small needles. And that is for your people who are providers who are maybe not very savvy with ultrasound, just starting out, don't have the capability, or having maybe a PA or someone who maybe doesn't have as much experience, or just doesn't want to take the time to do the ultrasound and the long needle technique, because there are pros and cons to all of these. And then the other side of the spectrum is the ultrasound guided long needle technique. I'm going to tell you that the population that's appropriate for will be the anesthesiologists, the pain providers, people used to using ultrasound guidance to get where they want to go. And then there's a intermediate kind of a methodology where you can combine the small trident needles with ultrasound to pinpoint the nerves you want to get. These are for people maybe who aren't so good at triangulation of getting a needle under ultrasound to hit the target you want. So it really can appeal to about everybody. We've been teaching a lot of people over the last 3 years, and they range from orthopedic surgeons and their PAs all the way to the other side of the fence with anesthesia, in between pain specialists and interventional radiologists. So it really depends on your expertise and your comfort level with anatomy, with ultrasound, and with triangulation. So there really is something for everybody.
Got it. Now, I have a question. So in anesthesia, we do our nerve block, and even though it's short term compared to you're saying the long term, and I would like a little bit more clarification on how long this intervention lasts, but we do our nerve block right before surgery, and we, get surgical coverage, potentially, as well as, post-operatively. What are we looking at here? Because you guys are surgeons doing this for your patients, and that just seems odd to me. I know you guys do injections of cortisone and all those different things, but Vin, why don't you walk me through that?
Yeah. So, again, if we talk about the patient experience, we have to start thinking about it holistically, not just the moment they park in the parking lot, right? Mm-hmm. And so if we think about the entire episode, it really starts from the moment I booked the surgery, where the patient starts thinking about the surgery all the way through to the end of their recovery. And so I think if we look at the preoperative space and the opportunities in there to impact the postoperative recovery, there's a huge gap, there's a huge void. And so if we think about the nerve regrowing 1 millimeter per day, if I freeze that nerve, let's say 5, 6, 7 centimeters away from its innervation point, then theoretically I'm going to get 50, 60, 70 days of pain relief, right? So I can now treat that nerve preoperatively at whatever time point I feel appropriate. So I think, in my personal opinion, not evidence-based, that the first 3 weeks-ish, 4 weeks after surgery are really the most brutal for most patients, somewhere between 2 to 4 weeks. So if we can get them through that window, I think patients will really appreciate that. So then if let's just say we have 60 days of pain relief, I'm going to burn, let's say 28 days or 30 days on the back end. So I've got maybe 20 days to play with on the front end. So I could potentially treat those nerves maybe 1 to 2 weeks before surgery. So I've got that kind of 4-week window postoperatively to help that patient as that nerve begins to regrow. Go ahead, Monty.
Now, prehab in the National Health Service in the UK, we're very keen on prehabilitation because, we have very little money and we don't like to spend too much of it on the bit afterwards. But prehabilitation, we're very keen on. This sounds like a prehab dream ticket from the point of view of present with limited mobility and pain. I get the freezer out and now I can get you on a proper exercise program,
right?
Quad built up or whatever it is.
So you can look at it exactly from two perspectives. One, if there's a patient, for example, on opiates going into surgery, and let's say I freeze this nerve 2 weeks before, can I potentially pull them off opiates because I'm getting them that recovery?
Right.
Because we are all reticent to inject steroids or anything into the knee within a month, if not 90 days before surgery. So what opportunities do we have to intervene during that time? And then number two, if they do have the pain relief, can they potentially start their quadriceps strengthening and all the other exercises preoperatively more effectively on their own, or get them in for therapy and things like that. So it opens up a lot of doors if we start, again, thinking about patients holistically, not just the time they spend within the four walls of the hospital. And so typically in my practice, we will treat those nerves about 5 days, 7 days before surgery. So I do most of my total knees on Mondays. So we'll treat them the Wednesday or Thursday before surgery. And that, for me, in my practice, is a sweet spot where I have enough time where if they're, in the beginning, I was worried when I didn't know any better and we were first starting to do this, would there be untoward consequences going to surgery, right? Hematomas, cellulitis, some kind of crazy neuropathic nerve injury or something like that. And so for me, I felt, that was enough time going to surgery where that issue would declare itself 5 days later if there was going to be an issue. And it turns out there really isn't after all our experiences. For other physicians, and Josh can probably speak to this, they will do it 2 weeks before because they're trying to line it up with their joint camp and their educational sessions and their pre-op testing. And so, you as a provider, as a physician, you can decide clinically where this fits and how far preoperatively you want to do this. There's some people that are thinking about maybe I do it as a stepwise. Maybe I do one 3 months before, right? Because if you're looking 3 months out, wean them off the opiates and then give them a booster freeze, if you will, going into surgery.
Oh,
that sounds
all
great.
kinds of ways. Josh, how do you use it?
Well, like Vin, most of the people I see are my patients. So I know that it can work within a week of surgery. And what I mean by that is, there are going to be some poke holes. And those of us that are orthopedic total joint surgeons and who know orthopedic total joint surgeons know how anal retentive we are when it comes to wounds around the knee at the time of surgery. And if you know what they're from and you know that little bit of bruising, which can occur, it's uncommon. But if you get someone who is anticoagulated and they come in a week or two before surgery, I'm not stopping that anticoagulation for the iovera and then again for the total joint. I just keep it on. These are small poke holes. But every now and then, especially with the long needle technique where you're going a little deeper and you're traversing more tissue, you may get some veins you don't expect and there's a little bruising. I know what that is because that's my patient and I've done that procedure to them. When I train people on this technique, typically they're not orthopedic surgeons or their PA that do this. It is somebody acting on behalf of an orthopedic surgeon, anesthesiologist, CRNA, pain specialist, interventional radiologist, somebody who's basically a hired gun, pardon the use of the term. And, so the patient comes and sees them 30, 40 minutes later, out, never sees them again. And then if that patient has bruising or these tiny little healing holes, which aren't ever an issue, but the optics of that are much better 2 weeks before surgery than they are 5 days before surgery. So if you're acting on behalf of an orthopedic surgeon and performing that procedure for him, I recommend to take all the variables out of it. Just do it 2 weeks before. Like Vin said, it still will be very effective post-operatively for a considerable amount of time. You're not losing anything, burning bridges. Do it 2 weeks before so you don't get an angry call from an orthopedic surgeon saying, what'd you do to my patient?
There's got to be a downside. What's the otherwise I'm getting off the call now to go and
and honestly, Monty, I am a skeptic and I'm a cynic just like everybody else. And what am I missing here? This can't be all roses and that kind of thing. And quite frankly, honestly, I'm struggling to find a downside to this other than, obviously everyone talks about money and, there's logistics involved and this is somewhat disruptive to the preoperative process. We kind of got a well-oiled machine. Where do I fit this in? Do I do it at joint camp? If joint camp's 3 weeks out, and all this kind of stuff. But from a clinical physiological perspective, from a scientific perspective, I struggle to find an issue. And the big worries, and probably a lot of your listeners, the biggest paranoia I had when I started doing this was, am I going to damage this nerve? Is there going to be some long-term neuropathic issue that is going to haunt me? And we all know what happens when you have nerve damage. It will haunt you and me, the patient, the system, the world. That is the worst outcome, right? And so I was extremely worried. Again, I read the science, but, was there going to be some long-term nerve damage and create more of an issue than I'm helping? And we haven't seen it. So I understand some people are incredulous and they're like, what's the catch? I still, to this day, I struggle to find a really legitimate downside to this.
Yeah. And Josh, from you?
So we've done 900 of these. We've done a combination of the 3 needles and the long needle, focusing primarily in the last couple of years on the long needle when that became available. And I agree 100% with Vin. It is such a benign procedure. You have to be precise. There is some precision needed, especially with the long needle. Pardon this. This is not going to come out maybe offensive, but I've seen anesthesiologists do blocks and they, the Dr. blocks, they get close and they just blast it with lidocaine. That's okay. It's a grenade. Blocks are a grenade. You get it close, you get a lot of volume in there, you're good to go. And that's quick. iovera with the long needle and ultrasound is a sniper rifle. You need to be precise. You need to get on the nerve. You can't be close. The only downside I see is a partial treatment of a nerve. But if you're trained appropriately, you know how to avoid that. And you know when it's happening. It typically happens within a week or two. Patients get symptoms that are suggestive of a kind of a peripheral neuropathy in a way, pain in the distribution of the nerve, burning. And how do you treat that? You bring them back and you fully treat that nerve a little bit upstream and it completely goes away. We've had maybe 10 of those out of 900, maybe a little more. We had some process issues that we learned how to avoid that. But that is really it. And it's such, you're right. What's the catch? What's the problem? Here's 2 problems I see. Besides that, recognizing not to partially treat a nerve. It's such a new procedure. We have some data out there, some evidence-based data, but we need more. And that's what we're working on. Vin's working on, I'm working on at other centers, so we can have some more universal acceptance, because it really is a game changer. And, it is such a benign thing to do to patients. We've actually expanded the indications. We're trying it in RLS patients. We're starting a study. We proposed, we've done it in a few patients. Actually, a med student that works with me, she volunteered for it. 2 years later, she's still having relief of 4 of her 5 symptoms, meaningful relief. And we only did one leg, and the other leg is still the same. And the one leg we treated 2 years later is markedly better. Yeah. So that and we've done it on some other weird things around the knee that aren't related to osteoarthritis, because if it doesn't work, you're partially numb for a little bit, it goes away. It always comes back. I'm 99% sure the sun's coming up tomorrow. I'm 100% sure that your nerve will fully recover.
Yeah. Well, gentlemen, I know that you are extremely busy in your daily job. So thank you so much for taking the time to chat with us. I would love to have a further conversation. I think there were a ton of things that we didn't even get to touch on. So if you would all be up for that, that'd be fabulous. 2 seconds. How do we get a hold of you guys? If people want more information about this, Vin, you go first. How do we get a hold of you?
Yeah, so you can find me. I've got a fairly large presence on LinkedIn, and then we've got a new educational platform called DocSocial, doc.social. And so you can find me there. You can go to the LSU Health website. You can find me there. I'm all over, I think. Maybe.
You are. It's awesome. No, that's so great. And Josh?
Hopefully soon they'll be able to find you in London.
That's
just saying.
I'm a little harder to find. OrthoNebraska.com. We also have a presence on Facebook. Vin's getting me into some of his social platforms too. I'm a little bit behind the times sometimes, but those are 2 good ways to find me. And
Great.
Yeah, you can reach out.
Thank you. Well, gentlemen, thank you so much. Look forward to future conversations. This is fantastic. Good luck in everything that you're doing, and fabulous work. Thank you so much.
Yeah. Take care. Thanks.
All right. Well, Monty, fabulous conversation with Dasa and Josh Urban, both from the U.S., talking about cryoneurolysis and some of the non-opioid interventions that we have for our joint patients. What'd you think?
Brilliant. Really, really exciting. We've obviously got to understand a lot more about it. We're doing a bit of reading about it. There's a considerable amount of literature. The concept of cryoneurolysis has been around for a long time. And like many of these things, it just gets to a point whereby you get closer to someone getting it right. And it looks as though we're at the beginning of that journey.
Yeah.
There's years of experience and hundreds of patients. I think people want to get their hands on it. Like all things, approach with caution. Sounds as though people need to get appropriately trained and to understand the upside. There's always going to be a downside done badly. And I think that was referred to.
Yeah.
So I think we're going to be talking about it a lot for the next year or 2.
Yeah. Super excited. I think it opens up a lot of doors. And one of the conversation pieces that I would love to have asked and had the time to, but, how do we as anesthesia providers, get into this space? Because it is something that's done, prior to surgery. So I think we're always looking for ways to expand, perioperative medicine, from the point of contemplation till what's 90 days out? What's the official?
It depends on where you are now. Some people are talking about, you should look at the year.
Yeah. Well, eternally, right? When it comes to quality of life.
Days at home and happy, 90 days. But increasingly people are saying, well, why don't we, a knee replacement? It's a bit tough to be judging whether that's been a good result at 90 days. You probably want to judge that at a year, because there's a lot of recovery to be doing. Yeah. But I think there, as was referred to, iovera, the technology, I think we should put the links in the show note. Yep. I understand there is only a single provider at the moment. So although we refer to it generically as cryoneurolysis, I think we'll put the single provider link in the show notes if you agree, Desiree.
Yeah.
And I'm really looking forward next to talk about the fact that we've been promised that liposomally encapsulated bupivacaine. So bupivacaine that lasts longer than our traditional block. It's not going to last as long as the cryoneurolysis, but we're excited to hear more about that too.
Yeah. Oh, I think we have some opportunities coming up where we're going to hear more from providers who are, in the US, we've had it for a while, several years. And, people have really taken to it and using it for some very specific procedures. So I think that there's a lot to hear on that front. So look forward to those conversations. Monty, we have a couple meetings and some things coming up soon, don't we?
We do. The great news is for EdPom within the virtual world is there are so many meetings coming up, but let's focus on, and people are starting to use our education hub, which has been great. The last 2 meetings we put on, we're using it like a carbon-friendly conference center. People have come to us and said, can we, let's call it rent the space, and we've turned the lights on for them and let them do their webinars or shows or conferences in our space. But our big one is the World Congress, coming up back end of June into early July, live from London. It's going to be 100% virtual, online from the point of view of how we present and broadcast it. But we hope that there'll be some hybrid events that people will organize for themselves. We're not encouraging mass gathering or traveling, but we know that people are increasingly keen to at least go to their workplace and socialize the opportunity to share the knowledge.
Yeah, I think I'm excited to kind of see this hybrid model kind of go forward, because I think everyone, as they were hesitant to jump into the virtual world, there's going to be hesitancy for hybrid world, I think.
Yeah, well, for full disclosure, our team at work, under the current social distancing rules, we had the Welsh Perioperative Medicine Society, which was a fully virtual event. We gathered in the same socially distanced meeting room type of environment that we do every day when we go to work.
Yeah.
And we said, actually, we're taking study leave today, but we're going to sit around tables, meters away from each other, mask wearing and all that stuff that goes with it, with good ventilation. And we're going to watch this together. And in the breaks, we're going to discuss. And it was just a breath of fresh air to have a bit of time to socialize, I think is the thing. But it's socializing the knowledge. Yes. Is the socializing bit of it, and getting excited about best practice changes again.
Yeah, I think we just had a little event, small event, but we were outside of the OR and it was the same group. And just to have that exchange of ideas has been so fabulous. So I really think if people are interested in having some hybrid events or, gather together, let us know if you're doing that. We'd love to reach out. We'd love to shout out and, collaborate. So
share best practice.
Yeah, absolutely.
I mean, we talked about some people they're booking into their favorite spa hotel for a few days, and great, watch it on the TV, all according to the rules that are available, and then get together to share your thoughts on what's allowed according to local rules. And some local rules are appropriately very relaxed, and some are a bit more stringent. And who will know what it's like by July? Yeah.
So that's the World Congress coming up in July. You can find it at edpom.org if you want more information. The tentative agenda, or we've come up with the agenda. We're just getting ready to launch.
We're putting more names on it, but the draft, the skeleton of the whole structure is there. Once again, it's the didactic lectures will be predominantly pre-recorded, apart from the major plenaries, and there's one major plenary per day. And then most of the program itself will be building the couch. It'll be lively discussion from global leaders in the space.
Yeah. Super excited about that. And let's see what we have. Some other things coming up this fall that we're going to be talking about with Dingle and Chicago, maybe.
As we call them, Badge of Dingle in Chicago. So we're really, really, really hopeful, because we have a corridor with the Republic of Ireland that the team will be able and welcomed to physically broadcast the Dingle meeting from the town of Dingle on the west coast of Ireland. There's a number of different reasons to want to be able to do that. Part of it relates to sanity, the beauty of the place, a treat for the team, and also the local economy, which want to help. But obviously, if there's any questions about the appropriateness or safety of that, we won't be doing it, if you see what I mean. But hence, it will be fully virtual. If you see what I mean, from the point of view of the way we share and broadcast it. We're just really hoping we do it from there. And we made a strategic decision to roll that into the meeting that we previously referred to as the Chicago meeting.
Yeah, EdPom Chicago.
Yeah, so the day will mean that when people are in bed in certain parts of the world, we'll start on the west coast of Ireland. As we do workshops in the afternoon in Ireland, there'll be morning workshops in Louisville, Kentucky, for example. And then that will, in the middle part of the day, USA time, evening time in Europe, we'll have a transatlantic leadership forum and then segue into a more US tilted perioperative practicum for the evening. And those programs will start to appear. Those of you who are familiar with the Dingle one is very much current controversies, which we're taking on some big hot topics there.
Controversies. Yes.
Controversies. Is that, sorry? Is that controversies? Sorry, I learned to speak my own language, or the language of the country my parents took me to as a migrant child. The controversies. What did I say? Controversies. Anyway.
Controversies. It doesn't always translate.
Whatever it is. Things we don't always necessarily agree about, how to pronounce the word. And the US-based component of it is very much our perioperative practicum. Yeah. That's the why we should be doing these things, but more importantly, the how to do these things, the practicalities of setting up an anemia clinic, setting up now I think we'll be talking about how to set up a cryoneurolysis clinic.
I think so. Yeah, absolutely. Adding that to the mix for sure. Well, Monty, thanks again for joining me. This was a great conversation. Excited to hear more from this team and others who are using it. Be sure to check out our website, ebpom.org and topmedtalk.com. You can find all of our conversations that we've had, which there's a lot. So we are going to be probably talking about in the next several months, figuring out what we're going to be how TopMedTalk is going to be going. So hold on for that. Yeah, Monty.
Hold on. And we have a regular newsletter now, which we promised, but now the wonderful team has got it going on a regular basis.
Yeah.
There's regular content going up on the Education Hub. So we changed the video components on that on a regular basis. You just need to make sure you subscribe, join the tens of thousands of subscribers we have now. And we're probably going to change the TopMedTalk format. Yeah. That's what we're toying with. We're going to send out a questionnaire to get people's opinions on it. Yeah. But we think we're going to change gear things up a little bit in July, August for TopMedTalk.
Yeah.
So for regular listeners, it's only going to get probably better.
No, it's going to get better. You just may not hear from us every single day. It's going to be interesting. I don't know. Hold on for that. And
experiments are sometimes good.
It is growing. Okay, I just saw a quote today. Actually, it's not a quote. It was from the .social platform that Vinod was talking about, and it's called. It said "Semper Descens, Semper Crescens." Do you know what that means? How's your Latin?
Go for it.
Always learning, always growing.
Yeah.
That's what we do.
Beautiful.
It is beautiful. So on that note, you can always learn more about TopMedTalk on all the social media platforms, LinkedIn, Twitter, Facebook. We are there. And any comments, questions, anything like that, let us know at contact@topmedtalk.com.
And any cool new ideas. There's for once, there's quite a lot happening. We've got some other we've got a whole session coming up about novel pharmacology, because there's a whole, for the first time it's a long time since I think we've had some real new stuff, but there's some new tools coming out for us, which is great.
New therapies, new interventions, new tools, drugs, all kinds of cool stuff coming to the forefront. So we know we haven't been able to get to the meetings where a lot of that stuff is highlighted. So we're excited to do that and give those places a showcase, really. So thank you for listening to TopMedTalk. Have a fabulous day, and we will see you next time. Cheers.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.